Dear ladies and gentlemen, good morning, good evening. I'm Xiao Huang from Peking University People's Hospital. First, I would like to express my thanks to the Professor Multi for his kind invitation. The topic I give today is management of T acute lymphocyte leukemia 2012-2 update. T-cell acute lymphoblastic leukemia is a common hematologic malignant disease. It accounts quite of acute lymphoblastic leukemia. The number of diagnoses with acute TAL increased in recent 20 years. However, the overall survival is almost stable in recent 20 years. Most patients was younger than 20 years old, but they can occur in different age patients. The mortality seems not associated with age. So today I will be talking about the transplantation for T acute lymphoblastic leukemia, and then focus on the immunotherapy and novel agent. Finally, we are talking about the vision of total therapy for TLL. As we all know, for hematological malignant disease, there's multiple therapy for hematological malignant disease, including traditional chemotherapy and transplantation. Recently, identical transplantation has achieved greater progression, especially in recent series CAR-T or antibodies, the so-called immunotherapy or novel agent has occurred for the T acute lymphoblastic leukemia. However, even so, transplant remains one of the main therapy for T acute lymphocyte leukemia. Take the acute lymphoblastic leukemia, for example, according to CIBMTR, transplantation either with matched related donor, unrelated donor, or hypoidentical donor for different stage of acute lymphoblastic leukemia, transplantation can cure some potential of patient. Of course, if the patient received transplantation in CR1, and we can expect better disease-free survival. For patients with T acute lymphoblastic leukemia, here demonstrate that the ETP or near ETP have lower disease-free survival. Transplantation can increase the disease-free survival compared to chemotherapy, at least for ETP T acute lymphoblastic leukemia. Interleukin 7RP wild type compared to mutated TLL can benefit from transplantation. Here demonstrated after transplantation, interleukin 7RP wild type of patient have a significantly lower relapse rate compared to chemotherapy. This translates into better disease-free survival for patients with IL-7RP T acute lymphoblastic leukemia. However, other type seems not benefit from transplantation. Our group finished a prospective study 2 years ago that has been published. We compare identical transplantation with conventional chemotherapy for acute lymphoblastic leukemia is relatively young. Here, including B-cell lymphocyte leukemia and also high-risk T lymphocyte lymphoblastic leukemia. Here, this is patients characteristic with chemotherapy only our transplantation group. there seems no significant delay in patients' characteristic. Of course, our data demonstrate hypo is significantly lower relapse rate compared to chemotherapy. And however, hypoidentical transplantation has relatively higher treatment-related mortality compared to transplantation. However, even though the leukemia-free survival and overall survival is significantly better after transplantation compared to chemotherapy. And the subgroup analyze subgroup with T acute lymphoblastic leukemia analysis also found that after transplantation, relapse rate was lower compared to chemotherapy. However, treatment-related mortality was higher after hypoidentical transplantation. However, the leukemia-free survival or survival is better after hypoidentical transplantation compared to chemotherapy. These data indicate that with hypo transplantation patient protocol, T LL have significantly lower relapse rate compared to chemotherapy and better disease-free survival or overall survival. And also we analyze our retrospective data compared to pediatric patient with T acute lymphoblastic leukemia. This including totally 102 patients. Here we can find that after transplantation, the disease-free the relapse rate was significantly lower after transplantation. This translated better disease-free survival compared to chemotherapy. EBMT data with hypoidentical transplantation, as we all know, usually they use PTCY protocol. We can also find after hypoidentical transplantation, 7% of patients can achieve long-term disease-free survival. For example, for patients in CR1, nearly 50% of patients, half of patients can achieve long-term survival. And also, the EBMT contained the condition with can only contain the usually BUCY, majority BUCY or others condition that confound. Since TBI, so TBI-based conditioning have significantly better overall survival for younger patients. But for elderly patients, there seems no difference, although there seems no difference. And group from China also compared to TBI-based conditioning to BU-based conditioning. They also found that even for adult patients, the TBI condition have lower relapse rate, and this translates into the significant better disease-free survival, although the patient number was relatively small. And also our group indicate that fusion monitor-based MRD can predict T acute lymphoblastic leukemia relapsed post-transplantation. So we can usually in our centers regularly monitor MRD after transplantation, even for acute T acute lymphoblastic leukemia. And also the pre-transplanted FCM MRD can also predict the relapse rate if the patient demonstrates increased MRD after transplantation, then the relapse rate was was significantly higher than those with no increased group or compared to those negative group. So we can conclude from this data for T acute lymphoblastic leukemia, it seems that allogenic transplantation is preferred, especially for those patients in MRD or high risk, or patients in CR2 or beyond in respective donor type. Compared to TBI, comparing TBI or chemotherapy-based regimen for T acute lymphoblastic leukemia, TBI seems better in at least in pediatric or younger patient group. Actually, novel agent of will descend RCT are warranted in the future to confirm this conclusion. Then I'll be talking about the immunotherapy and novel agent. As we all know, transplantation remains one of the only cure therapy for relapsed or refractory leukemia. Of course, also for T acute lymphoblastic leukemia. However, we need more data to confirm this conclusion. Actually, in recent years, there are much more progression in the field of novel agent of immunotherapy for T acute lymphoblastic leukemia. Here is new therapeutic target for T acute lymphoblastic leukemia. We're talking about the inhibitor of DNA and the BCL2 inhibitor. Also, we are talking about the CD7-based CAR-T therapy. For example, we can use for neloxib for refractory or relapsed T acute lymphocyte leukemia. And here, meta-analysis indicate that after neloxib, nearly half of patients can achieve CR or PR, and then they bridge to the transplantation. There will be about 40% of patients can achieve the long-term survival. So this is also traditional strategy for refractory or relapsed T acute lymphocyte leukemia. Our Chinese group use CAG for refractory or relapsed T acute lymphocyte leukemia reinduction therapy. Here, my colleague reported their preliminary result that found, although the number is only 41, but it seems the CR rate is very high. 80% of patients can achieve CR. Those patients achieve the CR can bridge to the transplantation, and then over nearly 80% of patients can achieve long-term survival, although this is retrospective data with relatively small patients. Then I'll be talking about the potential the application of CAR-T therapy in T acute lymphocyte leukemia. This is the potential target for CAR-T therapy, especially CD7. Dr. Pan from Beijing Boren Hospital, the construct intra-broker CD7 CAR-T cells to overcome fratricide. CD7 CAR-T cell intra-broker the CD7 CAR-T cell can eliminate the CD7 blast that permit resistance present of CD7 negative normal T cells. use donor CD7 CAR for treat 19 patient relapsed after allogeneic transplantation. The number of CAR is from either the dosage, the response rate seems good because the nearly 85 patients can achieve MRD negative CR, quite a higher response rate. Here, we can find the CAR-T expansion. The CRS occur in many of patients, but fortunately, only 10% of patients are severe CRS. And because this is donor CD7 CAR, the incidence of GVHD after CAR-T therapy is 60%. Fortunately, it's only grade 1 over 2 GVHD. The CAR-T can be detected even half years after infusion. Recently, we published our data in Blood. We construct the natural selective CD7 CAR-T without the genetic manipulation. In vitro study or demonstrate that the natural selective CAR-T have availability after around 2 weeks of culture, and also demonstrate increased or stronger anti-leukemia effect compared to knockout CAR-T. And also preclinical study in mice model demonstrate that vitro expansion after 5 or 2 weeks after infusion, and also demonstrate greater anti-leukemia property, including here even a higher percentage of central memory T cells, and also we can find the natural selective 7 CAR-T even stronger anti-leukemia effect compared to knockout CAR-T. So we initial clinical trial, we enrolled 12 patients with refractory or relapsed T acute lymphoblastic leukemia cells. We use different dose of CAR-T cells for the treatment. After 1 month, we evaluate the result. We confirmed that MRD negative CR reached 95%. So this demonstrated the NS7 CAR-T therapy is effective for T lymphoblastic leukemia lymphoma. And 70 of these patients then bridged to the allogeneic transplantation. Before the end of this submission of the manuscript, all patients are survivors. The CRS rate occur in 19 patients. Fortunately, only 1 patient have grade 3 CRS. The icons also was grade 1. So commented by the Blood, they said our study added to the mounting evidence that CD7 is a clinically effective CAR detector for T-cell malignancy. And the most importantly, study should provide the much needed to detect the immunotherapy for patients with refractory or relapsed T-cell malignancy who otherwise have few effective treatment options. Dr. Zhang Mingzhe, the author construct autologous nobody-derived fratricide-resistant 7 CAR T, and also the clinical result was promising. 87.5 patients achieve CR. This we can find that we can monitor the expansion of CAR T cells. And Dr. Huang from Zhejiang constructed genetically modified CD7 targeting allogenic CAR T for a refractory or relapsed T acute lymphoblastic leukemia, so-called universe CAR. And also we can find the CR rate is 63.6%. Also because this is an allogenic universe CAR, so the response rate is remain very high. And my team also tried the CD147 CAR. This is the humanized single-strand variable fragment for CD147. This is second gen of CAR T frame. And also, this is CAR T exhibit potential safety to human cells and the CD147 deficient cells. This is the animal model. This is dosage of CAR T. We can find this CD147 CAR can confer robust protection against T cell progression. This CAR T was on the way to application for clinical trial. And also Dr. Si constructed CD99 CAR T for refractory or relapsed T-ALL. This is animal that also demonstrated it is effective. Then I will talking about the CD38. Daramap, as we all know, Daramap is one antibody for the treatment of multiple myeloma. However, for some T acute lymphoblastic leukemia, they also have CD38 expression. So this Daramap can be used for the treatment of patient with T acute lymphocyte blastic leukemia, and the two reports demonstrate that it seems effective for some of patients with MRD positive patient. Animal model also, preclinical model also demonstrate that the Daramap plus CD7A blockade is better. So they have a synergy effect. Then I will demonstrate some data from venetoclax for the treatment of venetoclax is BCL2 inhibitor, a block BCL2. They can use different type of leukemia, including AML or even PL or even multiple myeloma. Also, this data here demonstrate that venetoclax and navitoclax in combination can actually be used for the treatment of T acute lymphoblastic leukemia. The CR rate, our response rate is 52.6%. So we can conclude from this that the novel immunotherapy agent will improve the remission rate of refractory or relapsed T acute leukemia, extend the candidate who will be bridged to the allogeneic transplantation. Currently, CD7 CAR T may be the most promising salvage treatment for relapsed or refractory T acute lymphocyte leukemia. Other types of CAR T will develop continuously. Then I'll be talking about vision of therapy. As we all know, with the development of technology, we can find more and more new biomarker make the diagnosis of hematological malignancy more precise. Actually, we can combine it with all these type of newer biomarker to realize the precise diagnosis or personalized diagnosis, and then we can to do process treatment. This is a so-called process medicine. So for TLL, we have actually they have already a lot of biomarker can stratify the TLL. Recently, we have also published data. We used new technology. We found that actually HOX1 expression was associated with better disease-free survival. So maybe we can use HOX1 or HOXA13 to stratify the T acute lymphocyte leukemia. This is also only demonstrate that maybe in the future, the TLL can be diagnosed into the different subtype. Then we can combine transplantation and immunotherapy or novel agent to make the treatment more stronger. Here, this is our vision of total therapy for acute lymphoblastic leukemia. In the future, I think it might be after diagnosis, we need to do comprehensive genetic analysis. Then we can, based on pathway, to do multi-agent induction. If the patient was refractory or remain MRD high after multi-agent induction, then we can, based on the biomarker or to do immuno or novel agent therapy, and then a bridge to transplantation. If the patient get a low risk patient get a remission, then we do MRD monitor. If the patient persists in the MRD, then those patients might be cured by traditional treatment. If the patient was genetic high-risk patient, then maybe we can opt from the transplantation. Finally, I would like to acknowledge my team for this contribution to our center. Thank you for your attention. Thank you.